Hello, and welcome to tonight's Immunisation Coalition webinar. The topic this evening is on influenza disease, a 2025 update. You were listening to a Russian composer. It was classical music, of course, by Dmitry Shostakovich. Now, I'm sure I haven't said that right, but I haven't heard of this piece before, but I liked it, and I hope you did as well. My name is Andrew Minton. I am delighted to be your moderator tonight. I am the CEO of the Immunisation Coalition. So before I start, I'd just like to recite the Welcome to Country before I go through some housekeeping and introduce our guest speaker tonight. I'd like to acknowledge the traditional custodians of the various lands on which we work and acknowledge the Gadigal people of the Sydney area of which I reside, and all and any Aboriginal and Torres Strait Islander peoples participating in this webinar tonight. I pay my respects to elders past, present and future, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the various lands, animals and waters of Australia. So just a bit of housekeeping. You all know this, so I won't spend too much time on this. Presenting tonight's session is Angela Newbound. Many of you will know her. She'll be speaking for around 40 minutes. This gives us plenty of time for some questions and answers. If we don't get to all of the questions, we will be posting those out to you in about a week's time, together with a recording with the full set of answers. So wait for that. I'll do my best to get through as many questions as possible, and sometimes it's a bit of a rapid fire. If you're able to put your questions in the Q&A button, not the chat box, I'll be looking for those. Tonight's presentation will be recorded, and as I said, it will be available in about a week's time, but everyone is on mute apart from myself and our guest presenter. At the end of the webinar, we just have a 2-minute evaluation form. We do look at a number of those just to see where we can improve for our next webinar. So before I introduce our guest speaker, and I can see the slide is already up there already, I just wanted to take you through a couple of fun facts, some interesting facts, which our speaker will mention some of these in her presentation. So just looking at 2 risk groups around infection rates and vaccination rates, and looking at the national average for children under 5 for last year, the vaccination rate was 26%, as I said, for children under 5. In 2023, that was 30%, so we've gone backwards rather than going forwards. And in 2019, just before COVID hit, it was 44%. So we are going backwards with the children under 5. With the older population for adults 65 and over, the national average last year, and it does vary by state, some are higher, some are lower, 61%, so it's significantly improved in other younger age groups, but it still represented a drop of 8% versus 2023. Currently, in Q1, as we've just finished this quarter, infection rates, are up 55% compared to the same time last year. And remember, last year was a record year of 366,000 laboratory confirmed cases, and that's probably just the tip of the iceberg. And I really had to go back and have a look at the records to see what infection rates were that beat that, and I couldn't find it going back to 2001, I should say, sorry. The next highest was just before the pandemic of 313,000 cases. So, and that was steadily increasing as it has done in 2022, 2023, and 2024. So there's lots of reasons behind the decline. I can't name them all, but some of them are quite interesting, and I would like to share a recent NCERS study surveying 2,000 parents with children under 5. We've also done our own survey with 1,200 parents, and some of the outcomes and insights are very similar. 15% did not intend to vaccinate, parents did not intend to vaccinate their child this year, but remember, vaccination rates nationally were only 26%. 75% intended to, so intention is good, but actual is another thing. 55% of parents do not prioritize a vaccination appointment over other things, and other things were defined, and there were numerous other things, which I don't have time to get into. But it just sort of kind of suggests that parents don't see influenza as a serious disease for their child. Interestingly, 54% of parents did not feel guilty that their child was not vaccinated, so no concern there. And I think it comes down and back to whether parents see influenza as a serious disease or not. And 43% don't believe the flu vaccination protects their child and the community, and only 41% said they believe vaccines are safe for preventing the flu. So safe as in affected by misinformation and disinformation, because they are safe, and preventing the flu. They don't prevent the flu, but they certainly reduce the symptoms significantly. There were other barriers to vaccination uptake, including cost, access, time taking off work, competing priorities, and a whole list of others, which are all responsible for the decline in vaccination rates, not only in children, but across all age groups. So I think really the takeaway message from what I saw in this report was that the majority of Australians under 50, I would say, because once you get above 50, vaccination rates start to increase, just don't see influenza as a serious disease. And we're doing a lot in the healthcare space. And do we need to do more with the general public? That's the question. So introducing tonight's guest speaker, I'm privileged to introduce Angela Newbound. Angela is a nurse, an immunisation education consultant, and is a valued member of the Immunisation Coalition. Angela has been involved in immunisation program delivery in South Australia for over 2 decades, originally as a immunisation provider, and then in program coordinator roles within the divisions of general practice, SA Health Immunisation Section, the Medicare local network, and the primary health networks in South Australia until recently. She continues to provide clinical advice and nurse education across a variety of platforms, is particularly passionate about vaccination. I've had many conversations with Angela over recent years, and the role immunisers play in vaccinating the general public. So with that, I'd like to ask Angela to present on her topic, Influenza Disease, a 2025 update. So over to you, Angela. Thank you.
Thank you very much. What a kind introduction, and a great introduction to what this talk is going to be all about. So this is really useful, Andrew. I'm just going to share my slides here, so hopefully everyone will be able to see them very shortly. Okay. So now you know all about me. I'd just like to know a little bit about you. Who are you? Who has joined us tonight? Are you a GP or a medical practitioner, or a nurse, a midwife, an immunisation practitioner, maybe a researcher or educator, a pharmacist, or another type of healthcare worker, or completely other? So that would be very interesting. If you can just answer that audience poll, that would be great. Okay, how did we go, Anastasia? Okay, fantastic. So welcome to you all. So lots of nurses have joined, and some GPs and medical practitioners, perfect, and some pharmacists and a few others. So that's fantastic. Thank you so much for joining, and I really hope that there's a couple of points that I make in the presentation that sort of resonate with you. So look, you all know what influenza infection looks like, sounds like. You've probably, along your life journey, had influenza at some stage, but definitely we know that it's a contagious respiratory illness that's caused by the influenza virus. It can affect your nose and your throat and sometimes even your lungs. We also know that this particular significant human pathogen can cause both seasonal as well as endemic infections and also periodic and unpredictable pandemics. And we've just had a pandemic, but it wasn't an influenza pandemic. It was, of course, a coronavirus one. But we certainly know that flu illness is, really common, a really common cause of a human respiratory infection. And it's got significant morbidity and mortality associated with it. And I think, like Andrew was saying, a lot of people are thinking that flu's not a serious disease. It certainly can be a very, very serious disease. We know that flu can affect anybody at any age. It's completely indiscriminate, but we do certainly know that there are some populations in our communities that perhaps are at higher risk of influenza illness as well as those complications. But I think it's really important to also note that when we ask people about influenza and they go, oh, no, I've never had it. Well, actually, they probably don't ever know that they've had it. Unless you've had a swab up your nose every single day of your life, you probably don't know whether you've had influenza or not, because there have been some very robust studies that have been done. And one back in 2014 actually found that 1 in 3 influenza infected individuals was actually asymptomatic. So disease can certainly look very different in individuals. So looking at the flu virus and what it looks like and what it will do, we certainly can see those protein spikes on the surface of the flu virus, and the ones that we're really concerned about, of course, and we talk about most, is hemagglutinin and neuraminidase. Hemagglutinin is an antigenic glycoprotein found on that surface of the influenza virus. It binds to the sialic acid, which is present on the surface of its target host cells, so our human host cells. Then we know that that sort of facilitates the entry of the flu virus into our cells. The main function of the neuraminidase might be to remove the receptors for influenza virus from those newly formed virus particles, which allows them to be released and then therefore spread the infection. There's about 18 different hemagglutinin subtypes, so H1 through to H18, and there's 11 different neuraminidase subtypes ranging from N1 through to N11. So we're going to have some polls for you just to keep you awake, perhaps. So this is our first poll. So what best describes antigenic shift? Is it a random genetic mutation of an infectious agent resulting in minor changes in proteins called antigens? Or is it the accumulation of a series of minor genetic mutations? Or is it viruses that are closely related to one another? And this can be illustrated by their location close together on a phylogenetic tree. Or is it an abrupt major change in an influenza A virus resulting in a new hemagglutinin and or a new neuraminidase protein in influenza viruses that affect humans? So see how you go with this poll. Give you a few seconds. Oh, we've got quite the spread, haven't we? So the actual answer is D. An antigenic shift is a major change. It's an abruption, and this is what usually will lead to pandemics. Okay, so thank you very much for having a good crack at that one. Okay, so we know influenza viruses are classified antigenically. There's types A, B, and C. Influenza A and influenza B viruses are clinically important in causing human disease. Influenza C virus infections are really quite mild illness, not thought to cause any human epidemics, and they're not of concern to us. So we know type A flu or influenza A can infect animals as well, but current subtypes of influenza A viruses that really routinely circulate in people include influenza A H1N1 and influenza A H3N2. So type A flu viruses constantly change, and this is called antigenic drift. So there's just these little changes that happen season by season by season. And they're really just responsible for those large flu epidemics that we have been seeing, these high case reports. And it's only type A viruses that have really been known to cause pandemics. And the pandemic occurs when there's an antigenic shift. And this is when there's a really radical and abrupt change in influenza A virus hemagglutinins. And there's a couple of different viruses that combine and therefore really results in that exchange of hemagglutinins. And for example, H1 replaced by H5, for example. So it's something that is watched very, very closely around the world, and we will continue to see drift. We hope that we won't see shift too often. So the majority of individuals who do become infected with influenza will show symptoms, but not everyone. Like I said, it can be asymptomatic. We know that this virus is spread very easily from person to person by either breathing in those infectious respiratory droplets that are produced by an infected person while they're talking or coughing or sneezing. Aerosol transmission is a little less unusual, but can certainly occur within those real confined spaces, and particularly during aerosol generating procedures. That transmission of influenza viruses can also occur through direct and indirect or fomite contact. Influenza viruses may remain viable on hands for up to 5 minutes and persist on hard surfaces to 1 to 2 days. So if someone does have a cough and sneeze and they do cover with their hand, can live on their hand for 5 minutes. So if they've touched a doorknob or a computer, anything like that, then certainly that virus can live on that surface for a couple of days. Young children, we know, particularly less than 5 years of age, become infected more easily and often have repeat infections and are more likely to transmit influenza. They don't generally have good cough and sneeze etiquette, and they do remain infected for longer than what adults do. 7 to 10 days for children versus 3 to 5 days for an adult. So it's really concerning to hear that parents don't really think that flu is a big deal for their kids and they're not getting them vaccinated. But we definitely need to see those vaccination rates rise. Certainly complications can cause lengthy hospitalizations. That's the last thing that our health system needs right now. It causes ICU admissions, and of course, unfortunately, for some people, it can result in death. It is estimated that flu contributes to maybe about 3,000 deaths in Australia each year. We know that influenza-related deaths are often lost in the reporting system, and we'll go through some of those possible causes a little bit later on. So Andrew touched on this when he spoke earlier, just about the number of cases and how they've been rising. You know, clearly through the pandemic, we didn't see a lot of flu circulating because of all of these measures that were put in place. But certainly once our borders opened and we had people movement again, definitely cases have risen. So we've always known that influenza cases have been grossly underestimated. So, you know, we've got to understand, is there more flu around, or is it that people are actually being tested more because of their experience through the pandemic? But we still believe that there are many, many people that have influenza that do not get a test, and therefore there's no laboratory confirmation, and therefore those numbers are not counted in the National Notifiable Disease Surveillance System dashboard. So if we have a little bit of a look at these graphs, so this is the burden of disease currently, and this is to the 26th of March, so just a few days ago. There had been 43,248 laboratory confirmed flu notifications to the National Notifiable Disease Surveillance System. At this time last year, now remember we had a really severe flu season last year in regards to the number of cases. There were only 28,938 cases reported. So we are well above that. So I think if we look on the right-hand side, the graph is that little red line that's sitting right above all of those other coloured lines. This is the cumulative laboratory confirmed cases so far this year. So does this indicate that we're in for a significant flu season? Well, it might. It's certainly indicating that we've got an early start to our flu season, but we'll just need to be watching these notifications in the coming months to see whether or not we're going to have very, very high case numbers continue across the season. So far, this graph will just let us know once again that those high reports of influenza are in children that are under 15 years of age. In the first quarter of 2024, in this particular cohort of under 15-year-olds, there were 8,369 notifications, but so far this year, that has been well surpassed at 12,234 notifications. So once again, we come back to why is it that parents are thinking that their children aren't really affected by flu, and what's the urgency of getting them vaccinated. So we talk about flu cases, but let's have a little look about what is the strains that are circulating. So if we look at the left-hand side where you've got that nice big peak, that's the 2024 season, and we can see of the samples that were subtyped, H3N2 dominated, and that's that mid-range teal colour. All of the dark colours is unsubtyped influenza. And if you have a little look right at the bottom of that graph, you'll just see a very light blue, and that is H1N1. So if we're having a little look at the right-hand side of that larger graph, which is 2025, we will see that there was quite a bit of light blue, representing that it was a H1N1 season to start with. But if we sort of start taking a look on the graph on the very far right of the screen, we can see that H3N2 is starting to creep up. So once again, something to watch. Usually a H3 season has a more significant impact than a H1 season. So we're going to be watching this very, very closely. So here's another poll. So we know that healthcare workers tend to go to work when they are sick, And this is called sickness presenteeism. In other words, they are presenting to work and they are unwell. So have a guess what percentage of healthcare workers in Australia have admitted to going to work with an influenza-like illness. Is it 40%, 25%, 60%, 75%? Give you a couple more seconds. How do we go, Anastasia? Oh, very, very, very close. Well, there was a study in 2020 that suggests that it's 60% is the answer. So people going to work sick is not helpful for your organisation or your patients. So if they do have an influenza-like illness, they really should be staying home. So we can only hope that that behaviour has changed since experiencing a pandemic. So the number of influenza-associated deaths, like I said, that are reported, they don't really represent the true mortality associated with this disease. We certainly know from the Australian Respiratory Surveillance Report for the reporting period of the 1st of January 2024 through to the 1st of December 2024, that they reported that the majority of deaths were in those aged 70 years and over. However, there were 7 influenza-associated deaths in children aged 0 to 9 years. In the year of this reporting period, about 6.4% of patients with influenza were admitted directly to an intensive care hospital, which was from a Sentinel site hospital. So medium length of stay was a few days, and you can certainly see in the graph there that peak time for hospitalisations were sort of around August through to September. We know that there are some people that do experience a higher risk of complications from influenza, such as our young children and our older people that are over 65 years of age, and definitely in our Aboriginal and Torres Strait Islander people from 6 months of age. So it's important to identify these individuals in your clinic setting and certainly ensure that they are offered and counselled about receiving an influenza vaccine. So there are some people with chronic risk conditions for sure that we do need to be most mindful of. And you can see there cardiac disease, chronic respiratory conditions, etc. Severe asthma, a lot of people get confused about what is severe asthma. It is that the person is on multiple medications and has multiple medical attendances, either GP visits or hospital visits throughout the year. So we know that there's people with chronic liver disease, impaired immunities, etc., that also are at risk. Preterm infants. So if you are seeing infants coming in for their 6-week check, just double check what their gestational they were when they were born. We don't adjust gestational age in the immunisation program though. People with Down syndrome or people with obesity, but it just doesn't mean that all of these people are funded to have vaccine, but certainly it is recommended for them. So we really need to look at everybody that's 6 months of age and older for a flu vaccine. Definitely people that are in long-term care facilities, inmates of correctional services facilities are another group that should really be considered for a flu vaccine, just due to the high rates of influenza transmission risk as well, and the complications during outbreaks. And so, like I said, not all of these are going to be eligible to receive a funded flu vaccine, but certainly recommended. And so we've just got to continually remind ourselves as healthcare professionals, as well as remind our patients, that unfunded does not mean it's unimportant. And so we should be recommending flu vaccination to every single individual aged 6 months and older. We know that influenza affects the vascular system in multiple ways, and it is associated with a greatly increased number of pro-inflammatory, pro-thrombotic cytokines, and it causes that endothelial dysfunction. And so it is of great importance, particularly as somebody that has had a previous cardiovascular event, either a stroke or a myocardial infarct, or if they have diabetes, for example, then please be considering offering them a flu vaccine and really counsel them about receiving it. There's really a mounting amount of evidence that's supporting that influenza plays a really significant role in the development of atherosclerosis and the triggering of its complications. And major studies have been done to explain the factors that convert established and stable atherosclerotic plaques into unstable, life-threatening plaques. Acute coronary syndromes involve the rupture of those vulnerable plaques, which are usually non-obstructive. But of course, when those plaques do rupture or erode, then a thrombotic event will certainly ensue. And we really need to avoid that. So COPD, really mortality and utilisation of healthcare resources associated with influenza, really concentrated more so in the elderly and those with those coexisting diseases such as your COPDs. Certainly much of the morbidity and the mortality associated with COPD are due to acute exacerbations, and exacerbations can be caused by a number of factors, but the commonest cause is infection of the tracheal bronchial tree, and viruses play a very big role there. We know that influenza is among several potential triggers for asthma. Infection with the flu virus can exacerbate that inflammation of the airway and the lungs, and not only triggering the symptoms of asthma, but certainly making them worse. People are not more likely to get the flu because they have asthma, but they're more likely to experience the related complications such as bronchitis and pneumonia, and often require hospitalisation as a result of that infection. So even with people that have got mild and really quite well controlled asthma are at high risk of, really serious health problems from having the flu. So it, once again, very important that these people are vaccinated. Diabetes puts people at greater risk of any kind of infection, whether it's viral or bacterial. And people with either type 1 or type 2 diabetes, or even gestational diabetes, even when it's all well managed, are at high risk of the serious flu complications, which can often result in hospitalisation and unfortunately sometimes death. Flu infection can also make chronic health problems like diabetes worse. And this is because diabetes can make the immune system less able to fight infections. And acute illnesses can make it harder to control blood sugar, and glucose levels can impact the severity of an influenza virus infection. Hyperglycemia is related to the worst outcome in both bacterial and viral illnesses. So we've talked previously about death, and we certainly know, unfortunately, that a number of people do die from influenza-related complications. So people that are thinking flu isn't serious really do need some education. Pregnant women definitely have been shown to have increased risk for morbidity and mortality with influenza illness during seasonal epidemics as well as pandemics. Newborn infants born to mothers with influenza during their pregnancy, especially mothers that have had severe illness, are at increased risk of adverse outcomes such as preterm birth and low birth weight. Infants under 6 months of age who experience influenza infection have the highest rates of hospitalisation and death of all children. Vaccination with influenza vaccine in pregnancy not only protects the woman, but also the baby. And babies under 6 months are too young to be vaccinated themselves, but because they are at such high risk, it is so important to vaccinate the mother so they can confer those maternal antibodies across to the unborn baby. So the seas and the air is once again open to travel. In the financial year of 2023 to 2024, Indonesia was the most popular international travel destination for Australia, with over 1.3 million departures recorded. New Zealand and the United States were the next most popular destinations for outbound tourists. So travel is back. Flu travels very well on aeroplanes. So always consider a flu vaccination as part of the vaccines that they may require for the countries that they're going to be visiting. So obviously these risk groups are outlined a lot more in the Australian Immunisation Handbook. So it's often updated. So please, please, please keep remembering to check for updates each year. So this is our third poll for tonight. A lot of people ask this question, should we have 2 flu vaccines in the same year? But who is recommended to receive 2 doses of influenza vaccine 4 weeks apart in the same year? Is it children less than 9 receiving flu vaccine for the first time? Is it individuals having flu vaccine for the first time post a solid organ transplant or a hematopoietic stem cell transplant? Is it women who have already received a dose of influenza vaccine this year, but then they become pregnant later in that same year? Is it D, all of the above, or is it E, none of the above? So let's just see how people go. Couple more seconds. Okay, thanks, Anastasia. How do we go? Okay, yeah, it is all of the above. Absolutely all of the above. So children less than 9 years, if they're receiving flu vaccine for the very first time, 2 doses, 4 weeks apart. If it's if people's first year post a solid organ transplant or a hematopoietic stem cell transplant, 2 doses, 4 weeks apart. Women who have already received a vaccine this season, definitely, if they fall pregnant, to have another dose. Absolutely. We need them vaccinated in pregnancy to confer those maternal antibodies. So state and territory flu schedules are out and about. Also, the Department of Health have released the 2025 influenza season information. So please be familiar with all of the requirements and recommendations. So when's it the best time to administer? Well, it's a really good question, really, because we've seen these higher rates of interseasonal flu activity in all of these previous years. So, and we're seeing it again this year. So if you've got flu vaccine available to give out of your fridge, just start giving it. We do know that the optimal period of time that people are covered is around that 3 to 4 months post-vaccination, but the coverage is really expected to continue for the full season. So just get people vaccinated. We know that the virus changes, and we've talked about that beforehand. So obviously, so do the vaccines. And this year, they have changed slightly also. So we look at, what was in 2024, and we know that the strains that have been changed out is going to be a little different than what they were last year. So these are the vaccines that were have been approved for use here in Australia this year. You will note that the little white boxes are what is funded on the NIP. The ATAGI clinical advice, the Australian Technical Advisory Group on Immunisation clinical advice came out on the 3rd of March. So if you've not got a copy of that, please download a copy and have it very handy. This table was taken from that advice. And just really remember that there are different vaccines for different age groups. Please do those 3 vaccine checks before you administer. The first vaccine check is look at it when you're getting it out of the fridge. Then show it to the patient or to the parent or to another healthcare worker and check it again. Then just prior to immunisation occurring, have a look at the label that's on the barrel around the syringe and double check you've got the right vaccine. Once again, we've got egg-based vaccines except for the one cell-based vaccine, which is Fluvax Quad, which is included on the national program for individuals aged 5 to 64 years. However, it is registered for use and is available on the private market for babies from 6 months of age. And this cell-based vaccine, it's a subunit vaccine. It's propagated in maiden Derby canine kidney cells. It's an immortal cell line that was established from the kidney tissue of a healthy female adult Cocker Spaniel back in 1958. And there's quite a lot of growing evidence now that is suggesting that cell-based technology offers for a better match against the circulating flu viruses than what egg-based vaccines do. However, ATAGI are saying that there is no preference in using egg or cell-based vaccines. So there are a couple of enhanced vaccines for our older populations. We know that influenza vaccine effectiveness in older adults is something that we need to consider. And this is due to immunosenescence, which is that age-associated immunodeficient state that's really characterized by that thymic involution and functional decline, reduced T cell proliferation and impairment of the humoral and cellular immunity. So we need to treat these older adults just that little bit differently. Fluad Quad is an egg-based vaccine that contains the standard amount of flu virus, but it also contains an MF59 adjuvant. And this adjuvant really is about inducing a greater immune response than a standard dose influenza vaccine. So it's funded on the NIP for people 65 years and older, but it is not available on the private market. Fluzone High Dose is an egg-based vaccine which contains 600 micrograms of hemagglutinin of the 4 flu strains per dose, but it does not have an adjuvant. This is available on the private market. It's not funded under the NIP, and it is available for people from 60 years of age should they wish to purchase it. Remember that your nationally funded vaccines are only for Medicare eligible people. So any patient age 65 and older who does not qualify for Medicare could be offered Fluzone high dose because they would be ineligible to receive Fluad Quad. So it's something that you can consider. Flu vaccines can be co-administered with other vaccines. The Fluad Quad having the adjuvant, okay to be administered with Shingrix that also has an adjuvant. That's fine. Administer on the same day if you've got the opportunity. But if someone's happy to come back a few days later, then they can come back a few days later. But just take advantage of having the patient in front of you realistically. Okay to co-administer with your RSV vaccines and your pneumococcal vaccines, not a problem. So vaccine effectiveness and efficacy will really depend on the immunocompetence of the individual and how well the vaccine matches the circulating strains. However, vaccine effectiveness of flu vaccines differs from season to season. We just really need to have a look at what's circulating, how healthy is our individual. So we've talked about the enhanced egg-based vaccines, the adjuvanted flu vaccine, definitely more protection in preventing hospitalisation from influenza or pneumonia. The high dose, once again, more effective in preventing pneumonia-associated mortality than the standard egg-based. Cell-based, it does depend on what is circulating to how well that performs and outperforms the egg-based vaccines. Certainly performs better looking at a very, very large study across 3 flu seasons in the United States, performed much better with a H3N2 year, whereas a H1N1 year, there was improvement for sure, but just lower improvement than against a H3. Everyone's a little bit worried about adverse events, etc., but certainly we know that most of them are mild. We know that people with egg allergy, including egg anaphylaxis, can be safely vaccinated with flu vaccines. They should just receive a standard dose, but if they are egg anaphylactic, they should hang around for 30 minutes rather than the standard 15 minutes. Past history of Guillain-Barré syndrome, we know that GBS has been associated with flu seasons each year, including flu vaccines as well as disease, but certainly people are more likely to, unfortunately, develop GBS following an influenza infection than they are receiving the vaccine. There's some OSVAC safety advice around the management or the clinical pathway for GBS. So if somebody developed GBS within 6 weeks of having an influenza vaccination, there is a small risk of reoccurrence of GBS following revaccination, and that therefore may outweigh the benefit of vaccinating them. But this is a conversation to have with the patient and potentially with the specialists involved with that patient's care. Very, very quickly, Andrew's already touched on the vaccination rates, which are absolutely suboptimal across every age cohort, even the funded cohorts. So these children, 6 months to less than 5 years, it's a funded vaccine, and we only managed to get 25.8% coverage. The over 65s, a funded cohort, and only got 60.5%. Aboriginal and Torres Strait Islander are a funded cohort from 6 months of age, and yet we are still getting really, really low numbers. There were about 600,000 less doses of influenza vaccine reported to the AIR last year, and this may be having a really big impact on our health system. So we really need to do better in 2025. So we can certainly co-administer COVID-19 and influenza vaccines on the same day. If people are over 5 years of age, they do recommend a distance if you are giving COVID vaccine to very unwell children under 5 years of age. But I think people are certainly past the state of COVID, but it is still a very serious infection and it is still circulating in great numbers. So this is really easy for the public if people are getting a little bit confused. So things like this can really help people understanding, but really PCR testing is the only way to identify the pathogen responsible for any of these symptoms. So nurses, there's the majority of our audience tonight are nurses, and you are remarkable, as are all healthcare professionals, but you are really accessible to patients. You're really trusted, you're really credible. You've got lots and lots of touch points with patients. So please, please, please advocate for vaccination, question them, ask them about what's worrying them, why aren't they getting a flu vaccine, etc., and just try and address their concerns and really plant the seed of why we need to get people vaccinated. So just very, very quickly, we just know that some people are more at risk of serious complications from influenza disease. And these are the people that are funded to receive flu vaccine on the National Immunisation Program. Definitely have conversations with every single individual that you see. Always go through your practice management software and identify at-risk individuals and do your recalls. Every time a person presents to your practice or your organisation, use it as an opportunity to talk about influenza, what's happening, what's circulating, what are the numbers looking like. National Notifiable Disease Surveillance System data is available to anybody and everybody. So you can use that data. And remember, if they are coming in for their flu vaccine, you've got an opportunity to talk to them about other vaccines that might be recommended to them. And definitely it is mandatory to report all influenza vaccination encounters to the AIR. So Andrew, I wonder if there are any questions that might be in the box. I shall stop sharing and we'll see what's there.
Thank you, Angela. Great overview and very well presented. So yes, we have a number of questions. We have 7 minutes, but because I spoke perhaps a little too long in the beginning, we might go over a little bit of time, but we try and stick to just after 7. So I'll start with one question, and also Fiona asked the same question. For pregnant women, what is the timing for vaccination, which weeks? And I'd add to that and say, when is the cutoff period before birth? Does it go up to 36, 37 weeks? When does it sort of end, or is it not too late for that?
Look, great question. Flu vaccine can be given any time in pregnancy, first, second, or third trimester. Clearly, we want to get them vaccinated a good 2 weeks before delivery of the baby, though, because we need that 2 weeks for the mum to build her antibodies and then transfer them across the placenta to the baby. So the baby is born with some protection against influenza, but it can be given at any stage during pregnancy.
Okay, thank you. And remember, if we don't get through all the questions, these will be provided within a week's time with all the answers. This is from Dean, D-I-N-H, if I pronounce that correctly. Some patients over 65 years old have rejected the Fluad quad vaccine due to really misconception that the stronger formulation has more side effects. So you did mention in slide 35 the other vaccines, but do you have a preference of which ones those might be? And because there is a high dose for over 65, but all of them are indicated for 65 and over. And the billing option, because only Fluad quad is the one that's NIP listed.
Yes, correct. And once again, this is a really great question, and we've had this in previous webinars that I've done. Yes, because it's an adjuvanted vaccine, some people do react a little bit differently to the adjuvant that's in the vaccine, and they do get more likely to have more so localized injection site reactions. Talk to them about why that vaccine really is suitable for them, and is it better to have a bit of a sore arm and get better protection, or do they want to go with less protection? Look, any vaccine in an arm is a great vaccine. However, it's certainly the preferred vaccine, but you could talk to them about Fluzone high dose, giving them 4 times the amount of hemagglutinin in that particular vaccine to give them some better protection, and see what their responses are.
Okay, thank you. Here's a question from Stephen. Does the flu vaccine have activity against para-influenza viruses? They have those symptoms are more like common cold, but do affect children, I think, more than
Yeah, absolutely. No, there's no cross protection at all. And I must say that I have had para-influenza myself, and I can't believe how unwell I was with it. So it can be a significant illness for some people, but no, there's no vaccine against para-influenzas.
That's right. Can people who have an egg allergy have an egg-based vaccine, or is there a wiser option?
No, go ahead with an egg-based vaccine. If they're super, super cautious and they're super, super worried, then perhaps, you could be looking at the Flucelvax quad, the cell-based vaccine. But no, there's not enough egg protein in the vaccine to really instigate an anaphylaxis. So it's quite safe.
How has this year's flu vaccines changed from last year? And this hasn't been brought up, but they are changing next year to a trivalent, so there'll be a change there as
Yeah,
well.
correct. So the only difference with the flu vaccines this year, influenza A H1N1 stayed the same as last year. H3N2 is the one that changed for this season, and the B Victoria, B Yamagata are still in the vaccines and same as what they were last year. And that goes for egg-based as well as the cell-based vaccines. It was just the H3N2 strain that changed out. And yes, you're right. We are using quadrivalent vaccines, so 4-strain vaccine this year, where we'll be transitioning this to being a trivalent vaccine, because there's been no B Yamagata strain seen since 2020 anywhere in the world. So the World Health Organization has suggested that we could now drop that out of the composition for vaccines going forward.
And Caroline, it's a sort of linked to this one. Caroline asks, the vaccines representative of the Northern Hemisphere influenza strains, and that's typical what we manufacture against, right?
Yeah, well, it is. It is. That's the data that they use of what was circulating in the past season. That doesn't necessarily mean that what we've got in our vaccines is going to be suitable for the Northern Hemisphere's winter that is going to come at the end of our year, so during our summer later in the year. So, but it may offer some protection, and so we always talk to travellers, particularly if they're high-risk travellers, to whether they should have a vaccine before they travel late in our year and going into a Northern Hemisphere winter.
Okay. This is for the older population, I guess, or not that old, 65 and over. So to those that are receiving Shingrix, can they also receive influenza and maybe other vaccines at the same time?
Yes, they certainly can. Fluad Quad has an adjuvant as well as Shingrix. So there's just not a lot of data around those 2 adjuvanted vaccines, but ATAGI say it's okay to co-administer them on the same day, not a problem, just use separate sites. However, because there's lack of evidence, perhaps you could separate them by 3 days, but it is hard to get back to your provider after 3 days. So I would be vaccinating on the same day if it was me.
Okay. So if you caught influenza in January and February, should you get vaccinated later on in the year? And if so, how long after you were diagnosed with influenza?
Yeah, no, just get vaccinated as soon as you're well. As soon as you've recovered from your acute illness, you can be vaccinated against influenza, because often, maybe if you've had a swab done and it's been confirmed as influenza A, it hasn't been subtyped to whether it was a H1N1 or a H3N2, but it's unlikely that it was both of them. So you would still benefit from getting the vaccine. So as long as you're over your acute illness, get vaccinated.
Okay. So Lyndall asked this question, but I can't find the question here anymore, but I wrote it down. So Queensland and WA are still offering the free flu vaccination program. So Queensland from March until September, so that's 7 months. And WA, I believe, will offer it this year from May and June, those 2 months only. But interestingly, because we did some analysis on this, just because you offer it for free doesn't mean to say for all residents the uptake is going to increase. So in Queensland, it actually went backwards 7% versus 2023. And in WA, it went back 20% across different age groups. So free is great for those non-NIGP eligible, but the message to the general public still, I think, needs to get out there that influenza is a serious disease and you should vaccinate against it.
Yeah, and I think I think you've hit the nail on the head, Andrew, but I really think it's about communicating. And I was watching today somebody in Buenos Aires, she's the head epidemiologist at the Children's Hospital there, and she was saying that is their biggest problem with vaccine uptake, really is about the ability for healthcare workers to communicate how serious this disease can be and how important it is to be vaccinated. And they're struggling as well. We're struggling all around the world with this particular thing, but it's more about communication.
Okay, and maybe just one last question, because we're just over time. Combination vaccines, so they're coming.
Look, they're certainly in the pipeline, absolutely. So there's a COVID flu combination vaccine in the pipeline. There's a COVID flu RSV vaccination in the pipeline. Look, when we will see them is anybody's guess. Potentially it's probably quite possible that we might see a COVID flu combination next year on the market somewhere, but yeah, but we won't probably see the others for a little while yet.
Okay, and there's a number of questions around the cost of non-NIP vaccines, and I had a quick look for Fluzone high dose. I looked on the website, it was around $72, but that was set by the manufacturer. But you really need to ask your GP and ask your pharmacist what the cost is for those.
And shop around, ask around, because pharmacies will differ in price. And if you've got patients that have got private health insurance, then most private health insurance companies will rebate at least a portion of the vaccine cost back if they've had to buy it on prescription. So.
Okay, all right. I think we're going to have to call it. It's just over 7 o'clock. Screen, but we mind. We'll keep going. Oh, there we
Perfect.
go.
There we go.
So first of all, thank you, Angela, and thanks to the audience for your participation and engagement. As I said, this webinar has been recorded and will be available mid next week, and together with the question and answers, and we'll send those out to you via an email, because we have your details, so you'll get that in mid next week. So I would just like to highlight a couple of things. Next disease specific webinar, if you register on our website, it's on the 25th of June for pneumococcal disease. It'll be on our newsletter as well, so if you receive that, you'll see it there. We have a couple of other events coming up in June. We have a 2-hour RSV dinner meeting. It's a combination of speakers and a lengthy panel discussion, a multidisciplinary panel discussion, so don't miss that. If you're not at the CDIC meeting in Adelaide, that's fine. You can register online and view it online. And a few days after that, we have our 9th annual immunisation forum meeting in Adelaide on the back of the CDIC meeting as well. So if you don't manage to make it, you can still register online as well. That's an all-day event. We've just finished the program, looks fantastic. Covers a lot of different infectious diseases, and importantly, differing from the ASM, it adds a practical approach to tackling the problem of under-vaccination. So don't miss that. Very short survey will be sent out to you, as I said, just 2 minutes for evaluation form. So I really appreciate if you fill that in. Well, I'll end there. It's a good night from me. Thank you again for participating. Angela, you may want to say something.
I'd just like to thank everybody for spending their evening with us tonight, and I will get to answer all of those questions that came through. And thank you for being so wonderful out there and doing what you do, and keep on doing it. You're my superheroes. Thank you very much. And thank you for the opportunity to talk tonight, Andrew.
You're welcome. Thank you, everybody, and good night.
Good night.